Okay, everybody, welcome to this educational webinar on ciliopathies today, which is jointly organized by ERKNet, ESPN, and ERA, and specifically the Genes and Kidney Working Group from the ERA. My name is Nijenhuis. I'm an internist nephrologist from the Radboud University Medical Center in Nijmegen, and I will be your moderator today. And it is my pleasure to welcome you all, but specifically our speaker, Marijn Stokman, today. And Marijn is a clinical geneticist and a postdoc at the Department of Human Genetics of the Radboud University Medical Center in Nijmegen, the Netherlands. And she actually did her PhD on the molecular diagnostics of renal ciliopathies at the University Medical Center in Utrecht in the Netherlands. And she did a postdoctoral fellowship on therapies for nephronophthisis at the Imagine Institute in Paris at the lab of Sophie Saunier. And she's currently also a work package leader in the big European TheraPs, which is an acronym for Therapies for Renal Ciliopathies consortium. And her talk will be on both isolated forms of nephronophthisis as well as syndromal ciliopathies. And she will educate us on the molecular background of these ciliopathies, but will also give us some clinical recommendations on the follow-up and will update us on current and future therapies. Before giving the floor to Marijn, I would like to urge you to pose your questions to Dr. Stokman in the question box in order to have some discussion on her talk afterwards. Well, Marijn, the floor is yours.
Thank you, Tom, for this very nice introduction. Hold on, I'm trying to move my presentation now. There we go. So I have nothing to disclose, and I will talk about, first start with a case, and then about what is a ciliopathy, what is nephronophthisis, and discuss some syndromes of which nephronophthisis can be a part. Then discuss the clinical and genetic aspects and roads to therapy, as Tom told you, and end with some take-home messages. So to start with the case, this is an 11-year-old girl who presents with kidney insufficiency, and she doesn't have a history of kidney disease. Her medical history reveals nystagmus at birth, hypotonia, and developmental delay. And you make an ultrasound of the kidney, and you see increased echogenicity. And when you check her urine, she has a bland urinary sediment and no significant proteinuria. So what would you do to make the diagnosis? And we'll start actually with one of the first poll questions right now. So who would start by making a kidney biopsy, and who would prefer to do genetic testing first? So you can now all vote.
So the poll is open, and I will wait another 30 seconds and then close it.
We are actually still stuck at only 60% of you who have voted, so I would like to urge everybody to punch in their vote.
All right, I was curious to see, but actually 80% has voted for genetic testing first. I think there's not really a right or wrong answer here, but I'm quite happy to see that many of you start with genetic testing because it's actually a very quick way to find out more. I don't know, my screen looks different now. Do you still see my presentation?
We are still seeing your presentation, yes. Yeah.
And in this case, the past history of the patient with developmental delay, and nystagmus was really suggestive of a syndromic cause for her kidney disease. So when you make an MRI scan of this patient, you see a molar tooth sign. And you can see the molar tooth sign in the figure here on the right. So this is an anomaly of the cerebellum. And actually, because of this developmental anomaly, it has the shape of a molar tooth. And this is very characteristic of a syndromic ciliopathy called Joubert syndrome. Genetic testing revealed a homozygous deletion in the MPHP1 gene. So Joubert syndrome is one of the many ciliopathies. The prevalence is about 1 in 100,000, like most syndromic ciliopathies. And it is characterized classically by a triad of a molar tooth sign on the MRI scan, hypotonia and developmental delay. There can be additional features. So in the pictures, you see oral hamartomas, and there can be polydactyly, but also liver fibrosis. And about 25% of these patients develop chronic kidney disease, which can be juvenile nephronophthisis, but also infantile nephronophthisis, which is quite different. I'll come back to that later, which is characterized by enlarged cystic kidneys. And Joubert syndrome, like most of the ciliopathies that we will discuss today, is very genetically heterogeneous. So currently we know about 34 genes in which variants can cause Joubert syndrome. So Joubert syndrome is one of the ciliopathies. So what is a ciliopathy? A ciliopathy is really a class of disorders in which there is a problem with the function or the formation of the primary cilia. And cilia were first described a long time ago already by Anthony van Leeuwenhoek, actually here in the Netherlands in 1675. And he had developed his own a very primitive form of a microscope, which you see in the on the right hand side of the slide. And with that, he could look at protozoa, and he actually saw little leg-like structures moving on the side. And these structures were cilia, and they very much resemble the flagella, for example, from the sperm cells. So the first types of cilia that were described were the moving type, the motile cilia. Later, a different type of cilia was also discovered, and these were the primary cilia. So the motile cilia are very often multiple per cell, and the primary cilia are one per cell, and they are sensory organelles. So here you see a timeline of the discovery of the first motile cilia and then the primary cilia. And actually in the 1950s, because of better microscopy, we could really visualize them for the first time. They are present, the primary cilia, on many different cell types. So they were first described on neurons, but they are, as you will see during the presentation, they are present on many different cell types. And actually in 1997, they were changes in the primary cilia were described to be involved in nephronophthisis. So the MPHP1 gene was the first gene discovered for nephronophthisis. And then later in the 2000s, primary cilia were described to be involved in ADPKD as well. So the polysystem 1 and 2 genes were localized to the primary cilium. And with the advent of next generation sequencing, of course, the discovery of genes involved in the ciliopathies took flight and increased exponentially. So as I told you, there are many different types of cilia. So the motile cilia, which are, for example, present in the airways and involved in the movement of mucus in the airways, are multiple per cell, but the primary cilia are often one per cell. And this is the type of cilia that I will focus on in this talk. And they can be compared to antennae on cells, which are involved actually in many different very important signaling pathways that are important during development. In addition, the cilia are also considered to be sort of a molecular brake on the cell cycle. So components of the primary cilia are also involved in cell division, which means that cilia can only be present in non-dividing cells because those components are required to form the basal body of the cilium, for example. And some of the ciliar components have a role in the nucleus in DNA damage response signaling. So in addition to these very important signaling pathways, many ciliary proteins are actually also involved in cell division and DNA damage response. So altogether, these make that cilia have a very important role in tissue development and homeostasis, including in the kidney. So in the kidney, cilia are present on the renal tubular epithelial cells, pointing inwards into the lumen, as you can see in this figure. And so when we talk about renal ciliopathies, it's really a collective term that includes ADPKD, which is of course very prevalent, about 1 in 1,000 people, ARPKD, but in this talk I will focus on nephronophthisis and the related ciliopathies, which is the much less frequently occurring group. So we call nephronophthisis a ciliopathy because almost all of the currently 23 genes that are known for nephronophthisis encode proteins that localize to the primary cilium. So you can see, really think of them as the building blocks of primary cilia. And the proteins localize to distinct ciliary compartments. And these ciliary compartments are associated with specific ciliopathy phenotypes. So for example, the proteins involved or the genes involved in isolated nephronophthisis and Joubert syndrome, they mainly localize to the transition zone of the cilium. I don't know if you can see my, my arrow in the presentation or no. Can you see when I'm pointing at something?
Yes, we can see. Okay.
Oh, good. So the transition zone is here at the base of the cilium, and it's really involved in gatekeeping. So it controls which proteins can enter the cilium and which cannot. There's also the inversing compartment, and most of the proteins involved in in infantile nephronophthisis. So that presents really early on, before the age of 3 or even during pregnancy, localized to this compartment. And then there are the basal body compartments and the IFT genes. My presenter mode is on top of that, but it's the purple proteins. And when there are variants in those genes, these are usually involved with a skeletal phenotype, and I'll come back to that later. And then there are the BBsome genes, and variants in those genes usually result in a Bardet-Biedl syndrome phenotype. So when we look at nephronophthisis, the incidence is estimated there. Well, there's a really broad range, but I usually say about 1 in 100,000 to 1 in 200,000 live births. And it's actually the most important monogenic cause of end-stage kidney disease in children. This is different from the most important genetic cause, because then you can say it's kakut. But nephronophthisis is the most important monogenic cause, and it's responsible for up to 15% of end-stage kidney disease in children. And because of recent studies, we also know that homozygous deletions in the MPHP1 gene are also an important cause of end-stage kidney disease in adults, very often unrecognized. So we will go to the second poll question, and it's about the inheritance pattern of nephronophthisis-related ciliopathies. So what is the typical inheritance pattern of nephronophthisis-related ciliopathies?
So you have another 10 seconds.
All right, so I'm very happy to see that most of you have voted for autosomal recessive, which is true in most cases. So most of the nephronophthisis related ciliopathies are inherited in an autosomal recessive fashion, which means that both parents are generally a carrier. Carriers don't have any symptoms themselves, but when both parents are a carrier, there is a 25% chance that a child will inherit the trait from both parents and will have the condition. And then there's a 50% chance of their children being unaffected carriers as well, and a 25% chance of being not affected and also not a carrier. And there are a few exceptions to this. The most important exception is X-linked Joubert syndrome caused by a variant in the OFD1 gene. And then there are some genes in which heterozygous variants have been described to cause a phenotype, for example, the NEC8 gene. But in by far the most cases, the inheritance is recessive, so well done. So nephronophthisis literally means wasting of the nephrons. 3 subtypes can be discerned. So there's the infantile subtype with a presentation before the age of 3, the juvenile subtype, which is the most prevalent form, and it usually leads to end-stage kidney disease at a median age of 13. And then there's the adult form, of which we are now learning a lot more, but which based on symptoms and histological findings very much resembles the juvenile form. It is characterized by the classic triad of a urine concentration defect, tubulointerstitial nephritis, and in the older definition, it was end-stage kidney disease before the age of 30, but as I said, recent literature challenges that. And because presenting symptoms are rather aspecific, very often there's significant diagnostic delay. So in children, it is usually diagnosed about 3.5 years after the first symptoms onset in hindsight. So presenting symptoms can be growth retardation, polydipsia, and polyuria, or therapy-resistant anemia, and of course, children become more tired, or it's very often aspecific. And when you make an ultrasound, usually you don't see signs that are really discriminative. So you see small to normal sized kidneys. They can be hyperechogenic. There can be reduced corticomedullary differentiation, and in about 50% of the patients, we see cysts on the corticomedullary junction. So we used to think that nephronophthisis is primarily a cystic kidney disease, but actually the fibrotic phenotype is much more prominent, and we don't see cysts in all of the patients. And we also think that the fibrosis is much more important in the pathomechanism of why the kidney function declines. So when you look at histology, you see this tubulointerstitial fibrosis, you see cysts that arise mainly from the distal tubule, and you can see thickened and disrupted tubular basement membranes. But as I said, we often see very significant diagnostic delay, and when you make when you do a biopsy in advanced stages of chronic kidney disease, sometimes you only see FSGS and you see nothing really specific that suggests nephronophthisis. The infantile phenotype is, as I said, very different. So this is characterized by cystic enlargement of the kidneys, very often cortical cysts, and absence of tubular basement membrane thickening, and only minimal fibrosis. So actually, when this is seen, for example, during pregnancy or very early on in childhood, it very much resembles ARPKD. And it has a rapidly progressive disease course. And in this case, the cysts are much more important in the decline of the kidney function. So is it a recognizable phenotype? this is a little bit older study in which exome sequencing was performed in 79 families with pediatric onset chronic kidney disease and a suspicion of nephronophthisis based on the ultrasound. And this was a cohort that was enriched for consanguineous and familial cases. And actually, in 50 of those 79 families, a causal mutation was detected, but only in 32 of those in a nephronophthisis-related ciliopathy-associated gene. And in the other patients, they found variants in genes associated with renal tubulopathies, some Alport syndrome, Kakut, ARPKD, and sometimes we know from our own experience that it can resemble ADTKD as well. So quite difficult to recognize based on the ultrasound, which also supports doing genetic testing in an early stage. Of course, all of this is so much easier when there are extrarenal features suggestive of a ciliopathy. So in isolated nephronophthisis, it's very difficult to recognize based on the phenotype. But if there are other features, and as I said, there can be many because cilia are present on so many different organs, it's a whole different story. So there can be hearing loss, anosmia, retinitis pigmentosa, congenital heart disease, obesity, neurological features, for example, in Schubert syndrome that we talked about. And of course, so for this talk, we're mainly focusing on the kidneys, but it's really important to be aware of these extrarenal features. So to go to the second case, this is a 5-year-old male. He had a normal birth weight, and he had post-axial polydactyly at birth. And polydactyly is a feature that can occur quite often, especially in certain populations, and is not always an incentive for genetic testing. But what was remarkable was that he also had an onset of obesity during the first year of life, even though this was not part of his family history. He had mild motor and speech delay, and he had night blindness, and he also had unilateral kidney agenesis. And when genetic testing was performed, compound heterozygous variants in the BBS1 gene were found. So this boy was diagnosed with Bardet-Biedl syndrome, which also occurs about 1 in 100,000 live births. It's characterized by retinal dystrophy, central obesity with an onset that's usually during the first year of life, post-axial polydactyly, developmental delay, and many endocrine symptoms. So, for example, hypothyroidism or hypogonadism. Kidney disease is present in about half of these patients. So we see many of these patients as well in the ciliopathy outpatient clinic. And about half of those patients have a phenotype that really resembles nephronophthisis, but there can be a Kakut phenotype as well. And what's interesting is that if chronic kidney disease occurs in these children, very often it occurs very early in life. So we continue to monitor these children until adulthood, because there's a wide variety in when it occurs. But when you look at the literature, very often if chronic kidney disease occurs, there will be signs of it very early on, which is somewhat different from the other syndromic ciliopathies. We currently know about 26 genes to cause Bardet-Biedl syndrome. And again, there's a very high intrafamilial variability within the kidney phenotype. So not only between nephronophthisis and Kakut, but also within the same family, there can be children with the infantile form of nephronophthisis, so with very enlarged polycystic kidneys during pregnancy, even leading to a phenotype that's incompatible with life and termination of pregnancy. And within the same family, there can be children with Bardet-Biedl syndrome, but with a much milder, slowly progressive nephronophthisis phenotype, or no kidney phenotype at all. So that's good to keep in mind. So something that can be confused with Bardet-Biedl syndrome is Alström syndrome, which is characterized by an earlier onset of visual problems, more hearing problems and diabetes than Bardet-Biedl syndrome, usually no polydactyly and normal intelligence. But of course, there are many reports of developmental delay, and it's always difficult when there are visual problems to discern, is it a result of the visual problem, or are there really cognitive, is there really cognitive delay? Important to keep in mind here is that there is a risk of cardiomyopathy. So the heart should be monitored every so often, which is different from the other ciliopathies, in which there can be congenital heart defects, but not so much a phenotype that develops later on. And kidney disease is common. And as an exception for Alström syndrome, we know only one gene, the ALMS1 gene. So here's another case. This is a 15-year-old male. You see the pictures on the right when he was 6, and he presents with reduced kidney function. He also has a remarkable shape of his skull. He has a short stature, and during the physical examination, you see that he has a narrow thorax, pectus deformity, and short upper limbs. He has broad hands and short fingers and toes, and he has thin hair, so also ectodermal features. And when you perform genetic testing, you find compound heterozygous variants in the WDR35 gene. So this fits with the diagnosis of Sensenbrenner syndrome, or cranioectodermal dysplasia. This is a very rare syndrome, characterized by facial features. There can be clefting or craniosynostosis, skeletal involvement, and the ectodermal features, so features of skin, hair, nails, teeth, and kidney disease is very prevalent in these patients. And there are currently 6 genes known to be involved in cranioectodermal dysplasia. And so in this patient, we found a variant in the WDR35 gene, which is also called IFT121. And as you can see, so IFT stands for intraflagellar transport. This is one of the genes that is involved in the transport system actually within the cilium. So you see here a figure of a primary cilium, and there are actually cargo trains going up from the base to the tip of the cilium carrying proteins, and trains going down from the tip to the base. And so the WDR35 gene is one of the proteins involved in the transport system from the tip back to the base, which is called the IFT retrograde transport. And another protein within the same transport system is one that is quite interesting also in the context of kidney disease. So it's the IFT140 gene. And it's one of the genes that we knew for some time to be involved in Mainzer-Saldino syndrome. So as I said in the beginning, many of the IFT genes, if you find a variant in one of those genes, there's likely to be skeletal involvement in the syndrome. And so with variants in the IFT140 gene, the Mainzer-Saldino syndrome, you also see patients with a short stature, narrow thorax. There's these very characteristic cone-shaped epiphyses. And so this is a rare autosomal recessive syndromic ciliopathy with a kidney phenotype that is nephronophthisis. So small or normal-sized kidneys, massive fibrosis, and sometimes small cysts on the corticomedullary junction. And there's this principle in genetics that in general, and of course there are many exceptions to this, if it's autosomal recessive, is more likely to have a severe early onset presentation, whereas more dominant diseases, especially if there's missense variants, is more likely to present later on in life and sometimes have reduced penetrance. And of course, there are many exceptions. But in the case of this gene, it's actually really interesting because a while ago, it was found that heterozygous loss of function variants in this IFT140 gene actually cause an adult onset cystic kidney disease phenotype. So in the Genomics England database, in the cohort of patients with an ADPKD-like phenotype that was unsolved, they found heterozygous loss of function variants in this gene in about 2% of the cohort. And it's associated with a milder ADPKD-like phenotype. So here you see the comparison to variants in the PKD2 gene. And actually you see that the kidney function declines more slowly than in patients with PKD2 variants. So this is these are cystic kidneys that are often detected by chance. So as I said in the beginning, ADPKD is a very prevalent genetic cystic kidney disease, and we always used to know two main forms, so variants in the PKD1 gene and the PKD2 gene. But in recent years, and I think this is really interesting, we've come across many more atypical forms with a later presentation or more prominent liver phenotype, like Renal and ALG. And so the IFT 140 gene is also one of the genes that gives one of these atypical phenotypes, and maybe there are more to be discovered in the future. So what does all this mean for the clinic? If a patient comes in with a phenotype that could resemble nephronophthisis and you can confirm it with genetic testing, you have to be aware of possible extrarenal features, and there could be some monitoring advice for those. I will show you later on that many different genes can be involved, and based on the gene that's involved, you cannot always rule out the possibility of extrarenal features because there's a lot of overlap. Conversely, if a patient comes in with a syndromic ciliopathy, for example, Joubert syndrome or Bardet-Biedl syndrome, very often a monitoring of the kidney function is indicated if there's not a kidney disease already. So in our center, we have a ciliopathy outpatient clinic, and we always do a renal ultrasound when the diagnosis is made, but then we also follow up these children because, for example, in Joubert syndrome, we know that about 25% develops chronic kidney disease, and based on the gene effect, you cannot really predict who will develop the kidney disease and who will not. So we do yearly monitoring of at least blood pressure and proteinuria, and then the kidney function. And there can be different parameters to screen when indicated. So I've listed them here. And as I said, also really important to be aware of extrarenal manifestations. So currently for isolated nephronophthisis, we know 23 genes. And with those testing of those genes, we can detect a genetic cause in about 60 to 70% of patients. So it's very likely that there are additional genes that are involved that we just haven't discovered yet, or genetic variants outside the coding regions, or variation that we currently do not detect with the techniques that we are using. The most important genetic cause is homozygous deletions in the MPHP1 gene. And you will find those in about 50% of the patients in which you find a genetic cause. But there are many more genes involved in syndromic ciliopathies and many more candidate genes. And as you can see in this figure, this is an example of genes involved in ciliopathies with blindness. but you see here, for example, Bardet-Biedl syndrome, the short-hair polydactyly syndromes, cranioectodermal dysplasia that we talked about, Joubert syndrome, Meckel-Gruber syndrome, which is a very severe early onset perinatally lethal ciliopathy with large cystic kidneys. There's a lot of overlap in the genes involved in the different syndromes, which makes it very difficult to predict, based on the results of genetic testing, what the phenotype of the patient will be. So very often you will need to do reverse phenotyping and screen the patient for many different symptoms. So why do variants in the same gene cause different phenotypes? There are multiple possible explanations, and one of them is the type of variant. So we know, for example, that variants in the MKS1 gene, if you have 2 missense variants, they will cause a milder senior Leuken phenotype, so kidney disease in combination with retinal dystrophy. But if you have a missense variant in combination with 1 deleterious variant, it will cause Joubert syndrome, whereas 2 deleterious variants are more likely to cause this very severe perinatally lethal Meckel-Gruber syndrome. So this is about the type of variant from a paper where they looked at the influence of the type of variant on the probability of kidney disease, end-stage kidney disease-free survival. But there are many more different types of mechanisms that influence phenotypic variability. So as we talked about in the ciliopathies, it's also related to the ciliary module in which the specific protein functions. But there are also, for example, genetic modifier variants that contribute to what the exact phenotypic presentation will be. So what does that mean for genetic diagnostics? I've included a question about your genetic testing strategy. And I realized that this is very different according to the possibilities and the healthcare system in different countries. So this is more a poll out of interest, and there's not a really right answer for this question. So please tell me if you see a patient with suspected nephronophthisis, what type of genetic testing do you perform?
So you have another 10 seconds.
All right, so very interesting to see. So I did this webinar in 2020, and then one of the recommendations was still to start with targeted testing for the MPHP1 gene. And I'm really happy to see that this has changed. So most people now do a targeted enrichment for ciliopathy or kidney-associated genes. Currently in our center, we're doing exome sequencing with bioinformatic filtering of a gene panel. And some people are still doing summary sequencing of the most commonly affected genes. And I think in time, more and more labs will move towards a more untargeted approach with the bioinformatic filtering. And I think very good to keep in mind if you're doing a targeted type of sequencing that you will still need to look at the CMV analysis to look for that MPHP1 deletion. All right. In our case, and of course it's different across labs, but usually we do targeted testing if the familial mutation is known. So for example, when you see siblings of a patient with nephronophthisis, but when you first see a patient without a genetic diagnosis yet, we will do either exome sequencing or in the future genome sequencing, because this also gives us the possibility to remove the bioinformatic filter if we don't find the genetic cause, and look even further at all genes. There are also some downsides to very broad genetic testing. So there is a chance of finding a variant of unknown clinical significance. There's also a chance of an incidental finding. And sometimes, as I said, it's very difficult to say something about the prognosis or how exactly, what exactly the phenotype will be because of all this overlap between the genes involved in the different syndromes. So in the case of a finding of unknown clinical significance, one of the real advantages of ciliopathies is that you can visualize the cilia in cells. And sometimes this gives the opportunity to do a functional test, which will allow you to interpret a variant of unknown clinical significance. So you can look at cilia formation. Is there a cilium or not in patient cells compared to control cells? You can look at cilia length, and you can also look at the function of this IFT transport within the cilium that we talked about. So this is an example of cilium formation. So in blue you see the nucleus, and then you can use a staining for ciliary compartments, so acetylated alpha tubulin and ARL13B, which is a part of the ciliary exoneme. And you can just count the cilia that are formed under the microscope. Same with the IFT transport. So if there is a defect in the transport from the tip back down to the base, you can see an accumulation of the protein transport at the tip, and this can be measured. And you can do this in patient fibroblasts or also in urine-derived renal epithelial cells, so kidney cells derived from patient urine. And then you can plot the cilium length, for example, and the IFT transport on the x-axis, and you can, based on this, discern different groups and also distinguish patients from controls. So this can give you an indication if the patient, if the gene actually clusters within the group that you expect based on the phenotype and on other patients with variants in similar genes. So the current therapy for nephronophthisis is supportive, really according to the KDIGO guidelines for the treatment of chronic kidney disease. So there's treatment of anemia, of hypertension, proteinuria, but in the end, there's nothing really that targets the underlying disease mechanism and that can halt the progression towards kidney failure. So the only option in the end is renal replacement therapy. What's good to know is that nephronophthisis does not recur in the transplanted kidney. In ciliopathies, of course, there are also extrarenal features, and there are quite a few developments. For many genetic retinopathies, there is gene therapy, and also there are some pathway-targeted therapies, for example, for obesity and Bardet-Biedl syndrome, and maybe also Elstrom syndrome in the future. There's medication like setmelanotide that targets the melanocortin 4 receptor, and that has been really shown some promising results in decreasing hyperphagia and reported hunger in these patients. For the treatment of the kidney phenotype, there is some progress in recent years. So, for example, antisense oligonucleotide therapy, but all of these things that I will name now have only been tried in cell or animal models so far, so preclinical. So this is a family that was reported with a variant, a stop variant in the CEP290 gene. Actually, so you could very nicely again see the cilia phenotype in the urine-derived renal epithelial cells of these patients. So these patients had very elongated cilia, and by using antisense oligonucleotides, they were able to skip the specific exon in frame and actually induce a restoration of the cilia phenotype, but also the cystic phenotype in a mouse knockout model. So this is very promising, and of course, if you have these gene therapies, it only works for a very specific group of patients. So the patients should have variants in this specific gene, and then the exon should be able to be skipped out in frame. So it's very specific, and of course, it's very nice if you can have a therapy that targets an underlying pathway or a mechanism that can be applied to a larger group of patients. So in that, on that note, I'd just like to mention this study that was published very recently of prostaglandin E2 receptor agonists, which were able to restore the cilia phenotype in cells from patients with MPHP1 and MPHP4 variants. So the agonists are, this agonist is called alkylstadil, and it also showed very promising results in a mouse MPHP1 mouse knockout model in the kidney phenotype, but it was also able to restore the retinal phenotype. So very promising. And we are working, as Tom mentioned in the beginning, now in a consortium to develop these therapies further to become clinical trial ready, so to say, so that the next step is to test these in patients. All right, to finish off with some take-home messages. So nephronophthisis is an important cause of end-stage kidney disease in children. And also in adults. If you see a patient with nephronophthisis, be aware of extrarenal features that can be associated with a syndromic ciliopathy. We know that there is very high intrafamilial variability. So that means that based on the specific gene involved, we cannot really predict the chance of developing a kidney phenotype. So this supports the continuation of monitoring of the kidney function well into adulthood. You cannot stop when children are 18. You have to continue on until at least their 30s, but probably longer. And if you see a patient with chronic kidney disease at a young age, and you don't have a plausible explanation for it, please perform broad genetic testing very early on in the diagnostic process. Genetic testing is becoming quicker and quicker, so it's very worthwhile to do this to avoid more invasive diagnostics. This was the end of my presentation, and I would like to give the word back to Tom.
Yes, thank you very much, Marijn, for this very enlightening webinar, but maybe also a very puzzling webinar with all these different genes and how to use this in the clinical practice, I think. I see that we are already having some questions popping into our question box, but maybe I can kick off with one. because I saw your take-home messages, and these are of course very valuable. But you can also have additional questions on that. And to start with the last one, you say that with CKD at young age, you would advise broad genetic testing. And then the question, there are at least two questions already that pop up. One is, what is at young age? And the other one is, what type of genetic testing should we do? And at what time, actually?
Right, very relevant questions, I think. So I think the age is a little bit arbitrary. So definitely, I think under 30, if there's not another plausible cause, but I think it would also depend on the family history and other features, and is there consanguinity, and there are many other factors that weigh in, I think, that would support even doing it maybe under 50, depending on these other factors. But I think everyone will give you a slightly different answer for this. And then on the type of testing that should be done, so when I say broad, I think at least a gene panel of kidney disease associated genes or ciliopathy associated genes. In some centers, these are combined. And it also depends on the phenotype. So I think one of the very important lessons is, if you don't find a genetic cause doing this, a genetic cause is definitely not excluded. And if there's a very strong suspicion, you can remove the filter and look further into the exome data, because of course the filter is updated every so often, I think in most labs, but there could be genes that are just very recently published that have not been included in the bioinformatic filter yet. And also, as we're moving towards other sequencing techniques, there could be genes outside the coding, variants outside the coding regions. There could be structural variants that we're currently missing. There could be variants in the mitochondrial DNA. So if you have a patient and is very suspect for a genetic cause, but you cannot find it, please consult a clinical geneticist, because there can be causes outside the gene panels for kidney disease and ciliopathies.
I have a question from the question box here, and this is a question by, and I already apologize if I do not pronounce this correctly, but Oana Ailioe, who asks, I have a 66-year-old patient with an IFT140 genetic variant, and how can I predict outcomes for his family? And I think that that's a very relevant question. And I would also be interested to know, does that rely on the actual phenotype? And what if you have an IF140 autosomal dominant polycystic phenotype? What does that mean for the chances of, let's say, the autosomal recessive phenotype being present in the family? Or are these completely different variants or mutations there?
Right, so also indeed a very relevant question. So currently we're still finding out about the phenotypic spectrum of IFT 140. And as we don't know at the moment, for patients with a heterozygous variant, we are currently recommending for their first degree relatives to do the cascade screening, just like in ADPKD, and to do monitoring of blood pressure and proteinuria, just to be on the safe side until we know more. So even though I think in this case the chance of developing end-stage kidney disease is is small based on what we know now from literature. In our center, we prefer to be rather on the safe side and to collect more data to learn more about the presentation in patients with heterozygous variants. In patients with heterozygous variants who are in the reproductive age, we offer genetic testing of the partner to exclude the risk of having a child with biallelic variants in the IFT140 gene, so of having a severe syndromic ciliopathy phenotype. And of course, the carrier prevalence is not very high, but still, because we know that biallelic variants give the Mainzer-Saldino phenotype, we always discuss the possibility of testing the partner anyway.
I have a very clinically relevant question also. Not that the last one wasn't clinically relevant, but I really like this one. This is from Jens Koenig, who asks, if you have a genetically confirmed nephronophthisis early in life, do you advise patients to increase fluid intake of the affected child to a certain extent? And if so, is your personal experience that you can delay the onset of end-stage kidney disease? Which is, I think, a very interesting approach, let's say, in contrast to the gene therapy that you announced.
Yes, so a very interesting question. I'm really curious to hear Jens's experience with this as well. So I know that some of our nephrologists and some of our geneticists recommend this based on their experience. I don't have enough experience with this myself, but I'm really curious to know Jens's experience with this.
Okay, maybe he can answer it in the question box, and otherwise you can have some discussion afterwards. Yeah, the other thing that I was actually wondering is about your interpretation of variants if they are found. Is that now actually something that is applicable to routine clinical care, or do we still have to think of this as a research modality?
Right, so in our hospital, we see it as extended diagnostics. However, it is not paid for by the health insurance. So it's done in a research setting. So that means we do not say this is the amount of time in which you can definitely expect a result, because it's not so routine that the experiments are always performed. Sometimes it has to wait a little bit. But because ciliopathies are such a strong research interest in our lab, we always try to offer it in the case of variants of unknown clinical significance in ciliopathy genes. But sometimes parents say, well, a skin biopsy is a bridge too far because our child has so many diagnostic procedures. And it's postponed until the child, for example, has anesthesia for an MRI scan or has a small procedure. So some parents will say, for us, it's not worth it at this point because we don't know if a definite diagnosis will follow, and we will just wait until maybe more knowledge comes from literature or from more patients with this variant in the same gene. So it's not it's not routine diagnostics yet. I know that in another hospital in the Netherlands, they do offer simple testing of cilia length and number and call it diagnostics. But I think this automated test, the alpaca test that we do, is a bit more reliable, and well, we offer it in a routine manner as sort of extended diagnostics.
Mm-hmm. Yeah, I know, because these discussions are sometimes difficult, because for us as nephrologists, it sometimes sounds like semantics, whether something is routine or not. But I know for you as clinical geneticists, it's very important to make that distinction, whether something is really routine diagnostic result, or whether it's actually something that is in the context of research. Well, in the interest of time, because we have already passed the 5 o'clock time, I would like to end this webinar, but of course not before thanking you again, Marijn, for this very nice webinar, and also a lot of the comments in our question box are actually in agreement with my idea about your webinar. So that's very nice. I also want to ask all of you to look for our next ERKNet webinar again, which is, I think, at the 19th of November, which will be on the new guidelines for ADPKD. So also a ciliopathy, right? If you still haven't had enough of nephrogenetics, then at this very moment, so at 5 o'clock, there is an ERA Genes and Kidney Working Group webinar on how to interpret genetic results. So for anybody who is very enthusiastic to hear more about that, you now have to switch very fast to this next webinar. Okay, thanks everybody for being here, and hope to see you all again for our next ERKNet webinar.
Thank you, bye.